Most respected chairpersons, dignitaries, organizers of this fantastic conference. At the outset, let me thank for giving me this opportunity to be here on stage. This is the, I think, third time that I'm associated with SPIK. So let us first congratulate this extraordinary team for their fantastic achievement, led by Dr. Biniraj and his team. SPIK, kudos to you, salute to you. And SPIK is allowing Dr. Biniraj to do this. That itself is a big blessing. You need to have such an organization which is helping teachers to give back whatever they have learned to the society. So I salute this virtue in Dr. Biniraj and all the teachers. And I've been given the topic of diagnosis and treatment planning, or rather fundamentals in treatment plan. Why should we plan at all? Why should we plan? Well, I'll put forth few cases. Dr. Abe has made a lot of things easy for me. Sir has already discussed a lot of things which I wanted to tell. And Dr. Jiju also had told about, the future presenting as opportunities to manage failures in implants. Look at the slide. You have one implant placed in the palatal portion. What is the purpose of this implant? Look at that. See the angulation in which the implant has been placed. I'm sure we are not planning this. Look at that. Where is the implant going? Incisor is the victim. The patient has been promised a full mouth fixed rehabilitation. 4 implants in the anterior portion. How are we going to deliver our promise? A crown, second molar, see where the implant has been placed. There again, incisors to be replaced. Implants have been placed parallel to the floor, right? Implant fracture, implant failure, periodontal failure, ceramic fracture. These are complications and challenges that we'll be facing if we do not plan properly. So I hope I've conveyed the message that planning is important. It's not all. When we go overboard and when money is the only thought process. Look, there was a 10th implant for sure. There was a 10th implant for sure. Absolutely no effort in diagnosis and treatment planning. Patient suffers. We as a society will have to take the blame. So, coming to fundamentals of diagnosis and treatment planning, I would like to pay my respects, pranams and tributes to my sir, Dr. E. Muniratnam Naidu, and this team. We grew together over the last 20 years in implants. Dr. Sunita will be speaking to you today afternoon. So, what does an edentulous patient approach a dentist for? Any answers? Is it such a difficult question? They come for teeth. Fine. No doubt, no? This patient will approach a dentist for teeth, right? So the objective is replacement of missing teeth. And here the means is dental implants. Fundamentals of implant treatment planning. Diagnosis. What are we looking at doing during diagnosis? We evaluate the existing condition. Identify and judge departures from normal. For that you should know what is normal, right? Recognition and judgment that require thorough examination. It is inappropriate to substitute assumptions for observations. Treatment planning. What is the chief complaint? History of presenting illness, the medical history, the dental status. These are factors which we will discuss. I don't like the way I look. I don't like the way I look. I have worn dentures for 37 years and I can no longer function with them. Right? Two chief complaints. They are different from one another. The first one is the demand is for? Please answer. Aesthetics, excellent. The second one, the demand is for function. Right? So you should know what the patient is coming for you to deliver what they want. History of presenting illness. Cause, sir had shown a case of fractured tooth and how beautifully the tooth was removed. Did you observe that? The fractured tooth was removed so very well without causing any damage to the bone, preserving bone. Okay. It could be a periodontal problem. It could be a endodontic failure, right? And all these reasons have got their implications in the foundation, which is the bone, the architecture, the volume, and the quality of bone. Duration of edentulousness. When a patient comes to you telling that I just had a fall yesterday, I lost a tooth, you should have an idea about what the bone architecture would be. The patient comes to you, last 20 years I have been without teeth, now I wish to have some teeth. You should know what would be the volume of bone, what would be the density of bone. So it is very important that you take the history. Coming to medical history was that sir was speaking of. This is a beautiful classification by the American Society of Anesthesiologists. Class 1, where the patient presents with no organic disease, no systemic disease. Class 2, moderate systemic disease. The first one is very obvious, so I didn't spend my time there. Moderate systemic disease would be a controlled diabetic, a patient who is hypertensive, who is still taking medicine, a patient who may have had a bypass surgery or an angioplasty, still in good health, a person who's got an old history of chemotherapy or radiotherapy 10 years back, but now doing very well. These could be candidates whom you could accommodate for implants. Class 3 is severe systemic disturbance, seriously interfering with the patient's normal activity, multiple medical problems. You will have to be very guarded in your approach. You should see if your intervention is going to help the patient or do more damage. It's a very ethical question. Last week I had a call from a dentist in Thrissur asking if she could actually replace or do a full mouth rehabilitation for a patient who was on bisphosphonates till the last month. 79-year-old patient, wheelchair-bound patient. I asked her, what is the purpose? How much will you be able to help her? How many times will she have to come to your place? And what is the surety that the implant will succeed? Right? Last 3 classifications, of course, we are not going to try. Implants, one is a threat to life, where patients are expecting death within 24 hours and the brain dead. Dental status, you are looking at replacing a single missing tooth, multiple missing teeth, and completely edentulous patient. We are here, such a crowd is here because we have realized and recognized that implants have become the standard of care for replacement of teeth, period. Okay. Treatment planning. So when you're thinking of treatment planning, what are factors that you will come to mind? One is the prosthetic aspect and the other, as sir said, is the foundation. The bone and the prosthetic aspect. Bone. We need to know the bone. What do we need to know about bone? There have been a lot of things which sir has already told, but I'll tell you what are factors which will actually help you. The applied anatomy, applied physiology, the bone volume or quantity, the bone quality or the density, both of them you need to know. I'll briefly go through anatomic aspects. I won't spend much time. Sir has actually spoken a little about it. When it comes to applied anatomy, there are 2 aspects that I look into it. First one is limitations. Second one is variations. So when we speak about limitations, these are anatomic factors which limit the dimension of your implant, the length of your implant. So when it comes to the maxillary aspect, you will think about the nasal floor, the labial concavity associated with your which incisor? Anterior. Dr. Binny is here. You have asked all of them to remain silent. Which incisor? Lateral incisor. The labial concavity associated with the lateral incisor. Yeah? The sinus, the floor of the sinus. The fourth expansion, which is the sinus invagination. The expansion that happens at the expense of your alveolar bone. All these things limit the size, the length of your implant. Anatomic variation, sir, has actually dealt with it very beautifully. I'm not going to speak and spend more time on it. Mandible. What happens to the mandible as age progresses? What is the change in architecture, in shape? What are the challenges it poses? Look at the picture on the upper right side. See the amount of resorption which has happened. Yeah? You have a short cut section, isn't it? The cut section is short towards the left side. You have the inferior alveolar nerve lying at the crest. Look at the density. On one side you have porous bone in the middle with cortical bone all around. At the other side you have extremely dense bone. Isn't it? This is going to have its implication. See the picture down. Cut sections of the course of the inferior alveolar nerve. Yeah, at the lingula, it is towards the lingual portion. As it exists through the mental foramen, it is towards the buccal portion. So you need to know the course of the nerve, the anatomy, so that you can utilize it properly to place the best sized implant possible in that area. Applied physiology. I'm not going to spend much time. All of you will be knowing about the building blocks, the osteoblast, the osteoclast, bone lining cells, yeah, the osteocytes, architecture. I'll be spending some time. Modeling, remodeling. These are things that you should know. Repair and regeneration, and of course some time on wound healing. Architecture. Look at the two bones. One is maxilla and the other is mandible. The picture is obvious, isn't it? One is porous. One is porous. The density is less. Mandible, it presents a very dense picture. It's a very dense picture. So you could have two types of architecture in bone. One is compact bone and the other is spongy bone. As the name suggests, compact, dense. Yeah, the advantages, you will have very good stability when you place the implant. The stability that you achieve when you place the implant is called primary stability. Understand? So that is what we derive from dense cortical bone. So is it the best bone that you could have? What is the compromise in dense bone? Lack of blood supply, which means that wound healing can be compromised. Is that all? As you drill, there will be very good resistance, extreme resistance. What happens when there is extreme resistance? Heat generation. So you could have necrosis if the temperature goes beyond 47 degrees. So it's important that you go ahead using sharp drills, new drills with copious irrigations. Spongy bone. Why is it called spongy? It has got caves, cavernous bone, right? Cancellous bone, which means that there's tremendous amount of blood supply. Wound healing will be good, but stability will be less. So you need to have a good mix and match of compact bone and cancellous bone. Bone healing. Dentists can best relate to wound healing by appreciating the stages in which an extracted socket heals. What happens immediately post extraction? You have blood clot formation. Into the third day, you have wound cleansing. By the 7th day, you have granulation tissue formation. By the 14th day, you have the procallus formation. By the 30th day, you have woven bone formation, right? 30th day to 90 days, 120 days, what is happening? You have the woven bone which is being steadily replaced with organized bone. Which is organized bone? Lamellar bone. What is the benefit of lamellar bone, organized bone? It is better equipped to bear load. So if you're going to place implant in lamellar bone, the prognosis is going to be good. So whichever point you're going to place the implant, is it immediately post extraction? You should know what is the state of the bone around. Are you going to place the implant after about a month post extraction? You should know what kind of bed you're dealing with. Do you have to go ahead with the last drill, or do you have to stop early on in order to achieve good primary stability? Is that clear? So these are aspects which have profound influence in diagnosis, treatment planning. When to place the implant, when to load the implant. Is that clear? Bone quality or density of bone. Lacombe and Zaab in 1985, they made a beautiful classification. Type 1, largely homogeneous cortical bone. Look at the cut section on top. Dense bone. I hope you remember the picture that I showed you earlier. Extreme density. As you drill, you will generate heat. Yeah, even if you go ahead with the last drill, you might still find insertion of the implant difficult. So you may have to go ahead with bone tapping. Create screw threads so that implant goes inside. Unless you do this, you will struggle. And just because you have got extraordinary stability, it doesn't mean everything is hunky-dory. Blood supply is poor. Healing has to be cautiously looked upon, right? Second one is a thick cortical layer surrounded by dense cancellous bone. The best combination that you would like. Cortical bone for good primary stability and cancellous bone for good blood supply. Third is a thin cortical layer surrounding dense cancellous bone. Here the cancellous bone is still dense, but you're devoid of cortical bone. So primary stability can be a challenge if you do your normal osteotomy procedure by drilling. So you should look at alternate osteotomy procedures using bone expanders or burrs with negative rake angle like your Densa burr, or osteotome, so that you don't remove bone but compact whatever bone is existing there to achieve good primary stability. Lastly, a thin cortical layer surrounding loosely structured cancellous bone. It will be like butter. You need not prepare. You will insert the implant and the implant will go in the way it likes. There won't be any resistance at all. You will have to be very cautious, right? Mish has classified the same as D1, D2, D3 and D4. D stands for density. So we are here speaking about the quality of bone, the density of bone. You see the pictures, yeah? The one on the right side, the earlier picture that I showed you, is the best picture to exemplify what is D1 bone, extreme density. D2, usually seen in the mandibular posterior region, fantastic combination of cortical bone and cancellous bone. D3, maxillary anterior, maxillary posterior region. D4, poor density. Well, right? How are you actually going to identify the density of bone? Well, 15, 20 years back, before CBCT became popular here, we had to depend on conventional radiographs and tactile sensations. Here, as you move the cursor on the CBCT, you will have how dense the bone is down below. You will see the Hounsfield unit, and you are easily able to relate to the density of bone. When you have good density of bone, you are looking at good implant to bone contact or bone implant contact, which means that the stability of the implant is going to be good. The primary stability and the secondary stability, which we infer post osseointegration. And this is a reflection of good bone strength. When you're actually having good quality bone, you are looking at better prognosis. You are looking at a favorable loading period. You can even load early on. Patient has got a tooth avulsed. You're going to place an implant and you can give a tooth in a day when you have primary stability. And for that you need to have good bone bed. You should know what you're working with, right? When the bone strength is less, when the density is less, you need to be cautious. Okay, what are factors that you should look at? Increasing the implant surface area. How can you increase the implant surface area for better bone implant contact? Increase the size of the implant. If that is not possible, go ahead with more number of implants. If that is not possible, go ahead with bone augmentation. Wait till you have enough bone bed to go ahead with implants. Even if that is not possible, change the type of prosthesis. Do not always think in terms of fixed prosthesis. There are a whole lot of other solutions. Is that clear? So you should know the bone quality. After the quality, let's come to the quantity or the volume of bone. This is a picture which most of us would have come across. Okay, this is Atwood's classification. The pre-extraction, post-extraction, high and well-rounded, knife-edged, low, well-rounded, and the depressed. Okay, this is a classification which was there even before we came to know about implants, but has got tremendous relevance. Mish classified it into A, B, C, D. A is abundant bone, B is barely sufficient, C is compromised bone, and D is deficient bone. When I say compromise, it could be a compromise in height or width or both. So available bone, the quantity of bone is assessed under 5 parameters. 1, the buccolingual width. 2, the available height, which determines the length of the implant. 3, the mesiodistal length. 4, the angulation of the bone. 5, the crown height. Server showing big towers all over the world. Huge towers are vertical cantilevers. What did I say? Vertical cantilevers. They are load magnifiers. They are load magnifiers. No matter how much amount of resorption has happened, we always wish to promise the patient fixed prosthesis. Occlusion can be a severe damaging factor. I am not going to go into the detail of that for want of time. So height of the bone is very obvious. We have already spoken about anatomic limitations in the maxilla and mandible. Width of the bone, you would like to have at least 0.5 millimeter to 1 millimeter of bone buccally and lingually when you place the implant. Mesiodistally, the available bone. Yeah, so there are 2 factors which decide the diameter of the bone, which is the buccolingual one and the mesiodistal one, right? Whichever is lesser, I hope you listened, whichever is lesser defines or dictates the diameter of the bone. Okay? Available bone angulation. It would be great if all the bone available is perpendicular to the plane of occlusion so that whatever load happens is favorable. Implants are designed for axial load. Implants are designed for axial load. But can you always wish for having bone perpendicular to the plane of occlusion? It's not possible. With the resorption, you have seen how mandible resorbs, you have seen how maxilla resorbs. Most often, the bone is at an angle to the plane of occlusion. So it's not criminal to place an implant at an angle. You can always manage with angulated abutments, but you should know that angulated abutments are decided before you place the implant. It is not a solution for a mistake that you have made while placing implant. Period. Important. Right? तो क्या हुआ? Angulated abutment is there. Big deal. Solution. No, it's not a solution. It is a force magnifier again. So even as you classify the available bone for the patient, you should know what is it that you have to expect. That is why in this classification of A, B, C, D, by mesh, angulation is included. Is that clear? Finally, the crown height. As you have a resorption of bone, the crestal bone loss, you would still place implant and achieve prosthetic solution. But you should understand that as the length of the prosthesis increases, it is going to be a force magnifier. Okay, so shouldn't you do it? You can do it. But you should know to manage such situation. You should know what kind of occlusion you need to develop. You should know what kind of force is generated. Only then will you be able to find success. Coming to the prosthetic options. Well, this picture encompasses all the solutions that you can have prosthetically. You could go ahead with an individual missing tooth. You could go ahead with multiple teeth missing. You could actually have a completely edentulous patient. In all these patients, single tooth, multiple tooth missing, and completely edentulous patients, you will still have a fixed prosthetic solution. Okay, in completely edentulous patients and in certain cases of partially edentulous cases such as cancer resections, you may have a solution of going ahead with removable prosthesis. Clear? Now these prostheses can be cement retained or screw retained. I am not going to go into detail of that though. Now, what are the prosthetic solutions? Let us go ahead. Fixed prosthetic solutions can be of three types: FP1, FP2 and FP3. Fixed prosthesis 1 replaces only the anatomic crown, and this happens when the patient comes to you immediately post extraction, or it's a planned extraction, or it's a trauma. So the prosthesis replaces only the anatomic contour that is seen. When the patient comes, reports after a while, where some amount of resorption has happened, your prosthesis may have to replace the root form also, and that is called FP2. FP3 is when you replace the gingival portion also. Is that clear? So these are three fixed prostheses: FP1, 2 and 3. Then you have the removable prostheses. It's a continuation in number, RP4 and RP5. Right? I'll explain about the removable prostheses in a while. So that is the picture of FP1, 2 and 3. So it is a reflection of the amount of resorption that has occurred in bone, which has to be compensated by the height of the prosthesis or the length of the prosthesis. Is that clear? But you should understand, now you see the size, the length of the implant is reducing. The height of the prosthesis is increasing. And the crown root ratio, Anti's law, all of you must be knowing. Similarly, you have similar implications here. As the height of the crown or the prosthesis increases, it has got tremendous load in the crestal portion. Is that clear? So it's a force magnifier. You should know that, right? That's an FP1, it's in the posterior region. You could have a similar solution in the anterior region also, where only the coronal portion is restored. FP3, forget about the anterior region, look at the premolar region, root forms are being, that is FP3, the previous one was FP2, RP4 and RP5, removable prosthesis 4 and 5. What is the difference between RP4 and RP5? Two very significant technical terms on either side. RP4 contributes in retention and support. So whatever force comes on the removable prosthesis is transferred to the bone through the implant. It is transferred to the bone through the implant. The prosthesis is removable. But when the patient masticates, the force is transferred into the bone through the implant only. When it comes to RP5, for whatever reason, you are able to place fewer number of implants. So the implant's prime goal is to provide retention. Support is derived from the tissues, just like your complete denture. Just like your complete denture. Implants only improve the retention and stability of the denture. That is RP4. And that is RP5. Okay, distally there is no support from implant. Implant only anchors the removable denture in the anterior region. So what is the ideal goal of implant dentistry? Replace patients' missing teeth to normal contour, comfort, function, aesthetics, speech and health, regardless of the atrophy, disease or injury to the stomatognatic system. So you need to place the teeth where they were. The teeth have to be placed where they were. The patient has to look the way they looked. You cannot redefine their looks, right? Unless they seek for. Is that clear? So no matter wherever the implant is placed, teeth have to be placed where they were. So how do you go about doing the treatment planning? You need to design the final prosthetic treatment first. What does the patient come to you for? Replacement of missing teeth. Okay. Determine the implant position and number. You should take into account the patient's force factors. The density or the quality of bone and the quantity of the bone has to be looked at. And thereby you decide on the implant size and design. you need to develop a soft tissue to simulate that of adjacent teeth. When your patient goes to your friend and smiles, should the friend ask the patient, where did you do this crown? How many of you say yes? That was done in Susmitam, Kakanad. Or should it go unnoticed? How many of you say it should be unnoticed? It should be unnoticed. That is where your victory lies. That is where the artist in you becomes successful. That is where the scientist in you becomes successful. That is where your skill is expressed. And you need to work towards that. Treatment planning. Beginner selection. I assume most of you are beginners and you are looking at your future in implants. So, to have confidence, your case selection as a beginner is very critical. You would look at cases with adequate bone quality, adequate bone quantity, one or few teeth to be replaced. Anterior is not an easy one. So look at posteriors, preferably mandibular posteriors. Good articulation of dentition. Occlusion is clear. You are able to appreciate it very well. Diagnostic cast, clinical examination and radiographs. These are, sir is already told. So bone is going to be assessed for height, which defines the implant length. For that you need to look at radiographs including CBCT. The buccolingual width can be clinically evaluated using a bone caliper. We used to do this very commonly before CBCT came into being, right? And this defines the implant diameter. Mesiodistal length, you could use a periodontal probe or you could use a scale on a cast to define. I have already told the implant has to be, diameter is going to be decided by the smaller, the lesser one, right? The distance between implant and natural teeth should be at least 1.5 millimeter. It shouldn't be closer than that. Between two implants, it should be at least 3 millimeters. It shouldn't be closer than that. Why? Why not both the implants at 1.5 millimeter? How come you are able to go so close to the natural tooth? Natural tooth is surrounded by periodontal ligament, which is richly supplied with blood. So healing with the kind of blood supply is easy. But when you place two implants too close to each other, vascularity does not allow proper bone healing. So if you place them together, as sir said, you will have the bone loss. Coming to a clinical scenario, a simple case, right? Your height that you have measured in your radiograph is 14.5 millimeters, mesiodistal length is about 12 millimeters, buccolingual width is about 7 millimeters. What would be the implant size that you would choose? What defines the implant diameter? The buccolingual width. 1 millimeter of bone on either side, 7 minus 2 is 5. Length, it is the sinus, you can very well go up to 13 millimeters. So this is the way in which you decide in a simple case. When is advanced planning required? You have lack of bone. It is very close to critical structures. You do not have a jaw relation. You may have few teeth in the mouth, but they do not relate to each other. Completely edentulous. Yeah? High aesthetic demand. It is in the appearance zone. You need to work with the tooth and pink aesthetics. Right? There are so many scenarios where actually you need to work as a team. I work like that. I appreciate my periodontist a lot. In fact, Dr. Sunita has been a very inspiring person for me over the last 20 years. She is a periodontist. I work very closely with surgeons at Amrita who still come to my practice. AIDS, photographs in smile, mounted diagnostic cast, diagnostic wax up, CBCT with a diagnostic template. I'm not going to speak about photographs, but then I'll speak a lot about diagnostic casts. Particularly people from disciplines other than prosthodontics, it is very important you know the value of diagnostic cast and articulating the cast before you decide on diagnosis and treatment planning. Diagnostic cast, They provide information on final prosthetic treatment plan. It gives you an idea about occlusion, which you may not be able to appreciate with a mouth mirror, right? Edentulous ridge relationship to the adjacent teeth and the opposing arch. Where is the position of the ridge? Is it more palatally placed? If you place the implants in the middle of the ridge, will the prosthesis be a cantilever? Position of natural abutments, extrusion, rotation, tipping, aesthetic considerations. Tooth morphology, where facets, you may know the patient is a bruxer then. Direction of forces for the future implant, edentulous soft tissue morphology. The interarch space, arch relationship, the prosthetic space, how much prosthetic space you have, the opposing dentition, number and location of missing teeth. It helps determine the position and angulation of implants during surgery. This is a very, very valuable asset. I have CBCT reports done by renowned radiologists. I respect them a lot, but they have not seen the case. They have not seen occlusion. They don't know the prosthetic space when they look at the radiograph and write the report. So their report is not the basis on which you will have to execute your treatment plan. There are other factors that you need to see. Look at that. The mounted cast shows supraeruption. You know that there is no prosthetic space for the crown. There are so many cases I have come across where implants have integrated and then the dentist realizes that there is no prosthetic space. Both these teeth will have to be intentionally root canal treated. You may have to do a crown lengthening and then go ahead with the crown. Now these procedures will cost you, isn't it? And it shouldn't be a surprise to the patient. Look at that. The patient has come like this. You need to know what is it that you're going to achieve. What does the patient come for? Implants. Have they come for implants? No, they have come for their teeth, correcting their teeth. This idea has to go very deep into your mind. There's an old case of mine, it's almost 15 years old, but I wish to relate this always so that you people can understand how treatment planning is done. He's a victim of a blast in Bikaner. He came to us for rehabilitation and look at his picture. He has lost many of his upper anterior teeth, in fact lower also. Lower they did a bridge there. Upper he came to us. Lot of alveolar bone is also lost. You see the relationship of the bone to the teeth. If I were to place implants now, the implants would be placed lingually. Lingual to the lower anterior teeth. So how am I going to go about doing the treatment planning? You have the cast of the RPD that the patient was wearing. I did a trial denture to satisfy the patient's aesthetics. Yeah? And after that, what did I do? You see the picture down? The base plate as the temporary denture base. I've cut that off. Then I removed the teeth. Then I contoured the wax. I made an impression, made a model and made a stent. Gave it to my surgeons and I told, Bhaiya, I need this much amount of bone. And they laughed at me. Chalo, aap bhi aa jao. Please come to my theater. And that is where I understood the struggle these people have to augment good amount of bone. Iliac crest was harvested, the bone was split, tunneling was done, and the bone was placed. Okay, after which we gave a temporary denture, graft was placed, graft took up, and then I placed the implant. You see the picture down right? I have taken that picture at an angle for you people to understand that the abutments are now ahead of the lower incisors, making it easy for me to make the prosthesis and making the prosthesis that will live for a very long time because the force that is going to come to the implants is going to be very favorable. Now it is 15 years and he is perfectly fine. Okay, that is the prosthesis. So what is the treatment planning for implant supported prosthesis? Design the prosthesis first. You just need to go till the trial stage. Prospective implant sites have to be determined and bone in the area has to be evaluated for the type of implant. Diagnostic templates. I'll spend some time on diagnostic templates. It is very simple. You people are living in an era of digital dentistry. It is going to create a storm. You people better get into it or you will be lost. Okay. But before that, this is how we used to work, and you can still work. It is very cost effective. This is a denture base. You could use the old complete denture of the patient, or you could create a denture base. Yeah? The picture that you are seeing, they are GP cones which are heated, made into a ball and inserted into defects that are created in the intaglio surface. After that, you send the patient for CBCT. So when should you send the patient for CBCT? You should send the patient for CBCT after you have reached the trial denture state. Once you have satisfied the patient's aesthetics and function, you go about identifying the prospective sites of implant, place opaque markers there, then send the patient to CBCT, and something is very important. What? Call your radiologist and tell CBCT should be made with the trial denture in the mouth. Okay. Then you will be able to relate the opaque marker to the available bone. You see the picture on the right side? On the denture base in the middle, you have an opaque marker. Now here you will be able to identify. You will have multiple slices. If this is not favorable, you will be able to go a little anterior, little posterior. You will be able to identify very well where you are going to place the dental implant. Full mouth treatment planning. Look at this patient. We are going ahead with a maxillary full mouth. Diagnostic wax. Jaw relation has been done. This picture speaks volumes. Does it? Yes. Do you have a labial flange? Labial flange is not there. Why? Even without the labial flange, there is fullness. Understand? So this is a classic case for implant supported metal ceramic bridge. You could go ahead with a hybrid also if there is sufficient prosthetic space. Just think about a case where fullness has to be achieved with a thick denture flange. Can you go ahead with a ceramic bridge? Aesthetics is not just about teeth. Lip support is very critical. So you may have to go ahead with an RP4 just because the lip fullness has to be achieved. Is that clear? So in this particular case, look at this picture. This is the only way. This is the only way in which you can identify the prosthetic space. Particularly in a completely edentulous patient or in a patient where existing teeth do not occlude with one another. Only after you do jaw relation, after you remove one of the rims, that is the only way in which you can identify the prosthetic space. Now here, those blue lines that are seen are prospective implant sites that we are looking at for a good spread of dental implants anteriorly and posteriorly. That is the diagnostic stent with opaque markers. CBCT is made. You are seeing the opaque markers in the diagnostic stent. Well, you have the cut sections. Okay, it is numbered. You know where your incisor is being planned, where your canine is being planned, where your premolars and molars are being planned, and you will be able to relate the opaque markers. Are you able to relate the opaque markers? Yeah? Can you see that opaque marker? You know which tooth is there. Is it the first premolar or the second premolar? And then you can judge the amount of bone. This makes things so predictable. And once you have that, you decide on the number of implants, the angulation of implants, and then you execute. When you execute, whenever I work with a full mouth rehab, I will have a chart like this. And most often it is handwritten. And when I do that, I remove or reduce surprises to the maximum. I achieve what I set out for. But here you see plan A and plan B, implant dimension plan A and plan B. I am prepared for surprises. I am prepared for surprises. No matter how much ever we plan, we can still have surprises. Bone can fracture off. Bone density might be too bad. Okay. So that is the picture. Fine. We have placed the implants and immediately given a provisional fixed complete denture. Digital treatment planning. I will not be complete without this. You people have been born into the world of digital world, if I could call, or digital dentistry. That's a lady who came with an odontogenic keratocyst. We had to remove that. We could still save the mandible. We gave her an RPD, healed for 6 months. It was COVID period. She came very late. After which CT was made. We used the materialized software to identify where the implants could be placed. A surgical stent with medical grade resin was made, and the implant positions were identified. The surgical stent is screwed onto the bone. It is stable. Yeah, tooth and bone support it derives. After which we have gone about placing the implants and restoring the teeth. Right? This is the other extreme. These days you have the scanners. You have an STL file from the scanners. You can overlap that with the DICOM file, and the precision with which you can make surgical stent is improving more and more. And that is the final smile and restoration. This is my message. Patients report for replacement of teeth, and you need to achieve that first. Implant is a mean of achieving that solution. Okay. I hope I have communicated that. Thank you one and all. And I thank Dr. Biniraj and his team for giving me this opportunity to share little that I know about implants. Thanks for having me among these luminaries. Thank you one and all.
Thank you, sir, for that enlightening lecture. I now request the chairperson,